Hello, my name is Nicole White. I'm an associate professor, clinical, at the University of Washington in Seattle. I work at the Surgical Services and Hernia Center. Thank you for joining me today for this talk. The title is The Current State of Biologic Grafts for Hernia. I have no disclosures. The objectives are to give you a background on biologic mesh, talk about indications and current usage recommendations. So why biologic? Well, we were looking for a better product, less adhesions, a more natural product, more pliable, and more bacteriostatic. We needed an alternative solution. Comparing synthetic versus biologic mesh, the pros of synthetic are that they are good mechanical strength, but low cost. Biologic pros are mild inflammation, less fistula, and reduced fibrosis. The cons of synthetic mesh are they become stiff, they're prone to inflammation, there's a higher infection rate and fistula formation. And the problem with biologic mesh is mainly the higher cost and less mechanical strength. Biologic grafts are biomaterials derived from extracellular matrix, collagen, elastin, growth factors, and it's a balance between the degradation and incorporation of these factors. There are many different types of grafts: isograft between identical twins, autograft between thyself, and the main ones we talk about, allograft and xenograft. Allograft from the same species, xenograft from animal. Allografts are either autologous or donor from dermis and fascia, autologous from dermis, fascia, rectus fascia, or fascia lata. Xenografts, either bovine from pericardium, porcine from dermis, intestinal submucosas, or bladder muscularis. Allografts are used mainly for replacement of damaged tissues. They're harvested from a cadaver, host cells are removed, they're washed to render them non-immunogenic, and they're preserved and sterilized. And there are many techniques for these. Xenografts are typically used for soft tissue repair, hernia repair, abdominal wall reconstruction. They're also harvested, there is host cell removal, and there is preservation and sterilization technique. Unique to xenografts are the issue of cross-linking. So cross-linking is a double-edged sword. The positive sides of cross-linking are that it improves mechanical strength, it hinders degradation, which is also actually a negative because you need some growth factor release, which is hindered, and therefore it is not incorporated as well. This inhibits tissue remodeling and causes encapsulation, which can cause seroma and bacterial contamination. SAGE's website has a plethora of educational material, and I found this very well organized, thorough chart listing the different types of biologic implants, including the type of implant, whether they're cross-linked or not, and whether they're sterilized or not. In my research for this talk, I came across a very interesting article about biologic mesh implant and the FDA approval process. This article reviewed 20 articles meeting the criteria, and this was a total of 1,033 patients. Very interestingly, there were unreported conflicts of interest in 16 out of the 20 studies. FDA approval was based on equivalence to non-biologic meshes, which is a third of the cost. And there was really insufficient evidence to determine whether the extra cost of the biologic graft was associated with clinical efficacy in abdominal wall hernia repair. I'd next like to highlight the different usages for the biologic graft. Starting with the reinforcement of the hiatus in the peristomal region and of laparotomy incision, addressing biologic implant used as a bridge, and the usage in class 1 and 2 wounds and class 3 and 4 wounds. So I'd like to highlight this Sentinel article from my home institution here in Seattle at University of Washington regarding biologic prosthesis to prevent recurrence after laparoscopic paraesophageal hernia repair. So this was a long-term study. The initial study, however, was 108 patients with follow-up of 6 months. Recurrence rate in the biologic cohort was 9% versus 24% with primary repair. There were no mesh complications. The long-term follow-up at 58 months of 72 patients, there was higher recurrence rate, 59 versus 54%, and again, no mesh complications. Moving on to the usage of biologic implant in peristomal hernias. Well, there is actual good recommendation with strong evidence to support using synthetic non-absorbable mesh, not biologic mesh, when forming an end colostomy to prevent the formation of a peristomal hernia. There is no equivocal evidence to support using biologic or synthetic mesh when you're repairing a peristomal hernia. This comes to us from the European Hernia Society guidelines. So biologic implants are used in ventral hernia repair, but where should we use them? Should we use them as an onlay, inlay, or sublay? Well, this article looks at 68 patients over a 6-year period using cross-linked acellular porcine dermis. 57% were bridged or IPOM'd. Only 43% had a fascial closure. And the overall recurrence rate was high, 61%. The fascial closure subgroup was lower at 37%. And surgical site infection had correlated with higher recurrence. So should it be used as an onlay? Well, this is a small study, non-cross-linked acellular porcine dermal matrix, 22 patients, only at 7 months, 9% SSI and 27% seroma. Looking at another Sentinel study, the RICH study, this was a prospective multi-center single-arm study looking at repair of infected or contaminated ventral hernias with a acellular non-cross-linked porcine dermal matrix. 80 patients, 22 seromas, greater than 70% success at 2 years. Looking further into the usage in contaminated fields, this study compares synthetic mesh versus biologic mesh in clean contaminated or contaminated fields, class 3 or class 4 wounds. Looked at a total of 126 patients, 69 biologic versus 57 synthetic. Outcomes at 90 days. The SSO occurrence was less in the synthetic population, as was the SSI occurrence. The recurrence rate was also less in the synthetic population. At 20 months, there were 9% occurrence, and at 26% recurrence in the biologic arm. The last study I'd like to highlight is a cost study, essentially, looking at 5 different biologic mesh brands, non-cross-linked acellular dermis matrix. The recurrence rate was lowest in one of the xenografts. The average cost was quite high, with $40,000 per usage with the best performing xenograft, so quite expensive. In summary, overall, the usage of biologic mesh in hernia. In hiatal hernia, we believe it's safe but equivocal. In peristomal hernia, no, when you're performing the creation of a permanent end colostomy, use a synthetic mesh to prevent peristomal hernia formation. And it may be a good idea, biologic versus synthetic in peristomal hernia repair. The jury is out. Usage in an inlay or bridge, no. Really try to close the fascia. Onlay reinforcement, yes. As a sublay in the retromuscular space, yes. As an IPOM, no. In class 1 and 2 wounds, use synthetic. In class 3 and 4 wounds, yes and maybe. And that is my summary of current updates of biologic implants. I thank you so much for giving me this opportunity. Thank you to SAGES, and have a nice day.